everybody! Welcome to this week's edition of Let's Make a Drug Deal, where I, your host, Michael Ann, will attempt to fix all of your problems with prescription medication. So first today, we're going to have our first guest come out all the way from the cranium. Please welcome to the stage, the Brain. Hi Brain, how are you today?
Yes, thank you for having me. I'm from up north, I'm from the cranium, but it's kind of lonely up there because I'm the only one who lives there. But, it's fine.
Yeah, well, tell us a little bit about how you're feeling these days. What's going on with you?
Well, I just been having a lot of stress these days. Like, everybody needs me now. Like, the heart wants to beat, the eyes want to blink, the feet want to walk. It's like, it's too much for me. I think I need a vacation.
Oh, I see. You've been feeling some increased intracranial pressure?
Yeah, I think that's it.
Well, I hate to hear that, but we're going to talk about some things that will help you out and give you some relief, okay?
Okay, thank you. I feel better already.
But first, let's bring out our second guest and talk to them a little bit before we get into that, okay?
Alrighty.
Welcome to the show, our second guest, the Eyeball. Hey, Eye, thanks for being here. I appreciate you coming, but don't you have a twin brother?
Yeah, well, one had to stay behind so our human could see.
Well, that does make sense. Well, thanks for taking some time off and coming in and talking to us today. Tell me a little bit about how you're feeling. What's going on? You look a little red and irritated.
I am because, well, our brain has taken like a really long lunch break and I'm seeing double. Things are getting blurry, but this doesn't happen when our brain is off lunch.
Oh, I understand. It sounds to me like maybe you're experiencing some increased intraocular pressure.
Oh no, is that bad?
Well, it can be, but I'm going to tell you some things you can do to help get some relief, okay?
Okay, thank you.
So we're going to talk about osmotic diuretics. These are a type of drug that use osmotic forces to draw water into the lumen, causing an increase in urine output. Mannitol is the only drug in this class. It's given via IV infusion, so the patient would be in a controlled setting in the hospital. Mannitol is the drug of choice for the treatment of cerebral edema, increased intracranial pressure, and increased intraocular pressure. And it does this by using osmotic forces to draw the water into the lumen, and that increases the urine output for the patient. Mannitol is freely filtered by the glomerulus. It's poorly absorbed throughout the tubule, and it's mostly excreted unchanged in the urine. It also does not penetrate the blood-brain barrier, and it's very minimally metabolized in the liver. It has a very rapid onset, and the duration is only about 3 to 6 hours depending on the patient's renal function. So some precautions for mannitol. You want to use it cautiously in a patient with cerebral edema. Mannitol can accumulate in the brain, causing a rebound increase in their intracranial pressure. You also want to use caution in the patient with renal impairment. Need to do about 1 to 2 test doses just to see how they respond to it. You also want to monitor for central nervous system toxicity, which could be coma, confusion, lethargy in patients taking these drugs. It's contraindicated in patients that have well-established anuria due to acute renal failure, severe pulmonary congestion, frank pulmonary edema, an active intracranial bleed, and somebody that's severely dehydrated. Some adverse drug reactions would be pulmonary congestion, fluid and electrolyte imbalance is a big one, acidosis, edema, hypotension, irregular heartbeat, and nephrotoxicity. Some drug interactions. Electrolyte-free mannitol solution should never be administered with blood. And other major drug interactions are tobramycin, gentamicin, streptomycin, and most enema preps that have sodium phosphate in them. Mannitol enhances the nephrotoxic effect of those drugs. So some indications for use. It's widely used in the treatment of cerebral edema and increased intracranial pressure. It's also used for increased intraocular pressure. It can sometimes be used for renal protection during a cardiac or a vascular type surgery, and it's also used during renal transplants. some things you want to be monitoring on these patients would be their renal function, their serum electrolytes, their serum and urine osmolality, urine output, and on the neurosurgical patient, you should be monitoring for an increased cerebral blood flow because that could start a brain bleed back again. Patient education for these patients would be telling them to immediately report any kind of shortness of breath, any severe dizziness, swelling in their arms or legs, angina, mood changes, confusion, vision changes. Those could be indicative of some serious electrolyte imbalance. Some main takeaways for mannitol is that it is the drug of choice for increased intracranial pressure and increased intraocular pressure. It works by using osmotic forces to cause an increase in the patient's urine output. Dosing for an increased intracranial pressure patient would be 0.25 to 1 gram per kilogram per dose. That dose may be repeated every 6 to 8 hours as needed. For increased intraocular patient, it's 1.5 to 2 grams per kilogram over 30 to 60 minutes, 1 to 1.5 hours before their surgery. You have to keep up with their fluid and electrolytes. This can get out of hand fast since you're losing so much water, you're also losing sodium too. Strict I&O. Thanks everybody for tuning in to this week's episode, and a special thank you to our guest for being here. Join us next week as we talk to the pancreas about his tumultuous relationship with his beta cells. See you then.